fracture in most cases, shortening of the lower limb, vicious position of the lower limb in valgus or varus. If we have a fracture of the lateral hemiplateau, the knee will be deformed in valgus. If we have a fracture of the medial hemiplateau, the knee will be deformed in varus. Abnormal mobility in the frontal plane of the knee, or ontologically limited mobility, that means that the mobility of the knee is limited by pain, also crepitation, functional impotence, and we must check the pulse in the distal arteries, and we must check the sensibility and motility in the territories of the peroneal and tibial nerves, because any fracture at this level can be associated with lesions of the great vessels or of the nerves at this level. The diagnosis of such a fracture is based, of course, on the imagistical examination. First, we will ask for the classical anteroposterior and lateral X-ray view of the knee. The angiography can be useful if you suspect a lesion of the great vessels at this level, the popliteal artery and the popliteal veins. A CT scan is useful in order to determine the lines of fracture, the number of fragments and their dimensions, the displacement, and so on. While the MRI is very useful in order to detect the associated lesions of the soft tissue. We have an intra-articular fracture. At the level of the knee, we have not only bones, but also ligaments, articular capsule, and meniscus. And usually, fractures of the tibial plateau are associated with lesions of the meniscus. We must address also these kind of lesions, not only the bone. And we have a number of examples. On the left, we have a fracture, a type 2 fracture in the Schatzker classification, a split depression fracture of the lateral hemiplateau. And here we have the postoperative image after reduction, osteosynthesis with plates and screw. And here at the level of the depression, we have an autograph from the iliac crest. An image from a CT scan, that's a frontal slice in a CT scan. As you can see, we have a large depression and a smaller split fracture. In such a case, we will lift the articular surface. Here in the empty cavity, we will fill this cavity with autograft, and we will mount a plate with screw at this level. And this image, it's a three-dimensional reconstruction for a bicondylar fracture of the tibial plateau, so a type 5 fracture in the Schatzker classification. The treatment. We have two options, the orthopedic treatment and the surgical treatment. The orthopedic treatment is indicated in fractures without displacement, and it consists in immobilization of the region in a femoropodal or long leg cast for 6 to 10 weeks, with walking with weight bearing at 3 months after trauma. And of course, every time that you have an immobilization of the lower limb in a cast or in an orthosis, you must indicate thromboprophylaxis for the whole period of immobilization. The surgical treatment, which is indicated in all fractures with displacement, consists in open reduction or reduction under arthroscopical control or reduction under C-arm control. So the reduction can be controlled by three methods: by direct visualization, by knee arthroscopy, or by the use of the C-arm device in the operating room. After reduction, the osteosynthesis will be performed with plates and screws, plus or minus Kirchner wires, or in smaller fractures with screws only, plus or minus Kirchner wires. Example for each type of fracture in the Schatzker classification. As we already saw, the type 1 fracture is a split fracture of the external plateau. In fractures without displacement, the orthopedic treatment will be indicated. Immobilization in this kind of long leg cast. If the fracture is displaced, we will perform reduction and osteosynthesis with screws. This is the screw. And in this case, we have also two Kirchner wires. In the type 2 fracture, which is a split depression of the lateral plateau, and which is the most common type of fracture of the tibial plateau, the treatment in a displaced fracture consists in open reduction, lift of the articular surface, and after that lifting, we will have an empty cavity here. This cavity must be filled with something, because if we don't do so, when the patient will walk with weight bearing, the whole articular surface will suffer another depression. So this cavity must be filled. It can be filled with spongial structural graft like this one, which is usually harvested at the level of the iliac crest of the patient. That means it is an autograft. Or in older patients, we can use a bone substitute. And after that, osteosynthesis with plate and screws. Weight bearing is always allowed at 3 months after surgery. A type 3 fracture is pure depression of the lateral plateau without any split fracture. The treatment consists in lifting the articular surface, filling the cavity with an autograft or a bone substitute, and osteosynthesis with plates and screws. The type 4 fracture is any fracture at the level of the medial plateau. Like in the lateral plateau, we will perform reduction, plus or minus autograft if we need one, and osteosynthesis with plate and screws. All these procedures on the medial side of the tibia. The previous 3 fractures, the plate was on the lateral side. Here, as you can see, the plate is on the medial side. The peroneum is on the lateral side. The plate means it is on the medial side. A type 5 fracture, it's a bicondylar fracture. It's a fracture of both hemial plateau. The treatment will be open reduction, the use of grafts if we have depression with lifting of the articular surface, and osteosynthesis with plates and screws. Because we have fractures of the medial plateau and of the lateral plateau, usually we will mount a plate on the lateral side and another plate on the medial side. So 2 plates in the bicondylar fracture. And finally, the type 6 fracture. It's any fracture at the level of the tibial plateau associated with another fracture here at the level of the metaphysis or at the level of the proximal diaphysis of the tibia. We will do the same thing open reduction, grafts if it is required, and osteosynthesis with a long plate and screw in this case. Usually in orthopedics, the condition is to have three screws in three screws above and three screws below the fracture lines. So in order to do that, to have three screws below the most distal fracture line, we need a longer plate in this case. As I said, this fracture is at the level of the knee. The knee means bones, the femur and the tibia, but means also other soft tissue structures. The instability of such a fracture can be due to the fracture, but it can be also a consequence of the associated capsuloligamentar lesions. Here in the first image, we have a fracture of the medial plateau, but also a complete lesion of the collateral ligament of the knee. If we surgically treat only the fracture, after the immobilization and when the patient will walk with weight bearing, this knee will be unstable in the frontal plane. So when we perform surgery, we will treat the fracture, but we must also suture the collateral ligament, or we must perform a ligamentoplasty at this level. In the second image, we have a comminuted fracture of the lateral plateau, a complete lesion of the medial collateral ligament, and also a lesion at the level of the anterior cruciate ligament. The treatment will be reduction and osteosynthesis with plates and screws for the fracture, suture of the medial collateral ligament, and in the first phase or after a few months, ligamentoplasty of the anterior cruciate ligament. The complications. The complications are the same for the lower leg. They are early, of course, postoperative and late. The fractures of the diaphysis of tibia and fibula represent around 20% of all fractures. There are two main mechanisms. The direct mechanism, when the tibia is hit with a hard object or by a car in a road accident, or we have the indirect mechanism when the curves of the tibia are exaggerated by flexion, and that will lead to a transversal or oblique fracture, or the tibia will suffer a torsion like in the ski accident, and this kind of indirect mechanism will lead to a spheroid fracture. We can classify these fractures by using the AO classification. So we are at the level of the tibia and peroneum. That means that the first number will be a 4. The 4, this number is associated with any fractures of the tibia. We are at the level of the diaphysis. That means that the second number will be a 2. For the proximal epiphysis, we have 1. For the diaphysis, we have a 2. For the distal epiphysis, we have a 3. So 4, 2. If the fracture is a simple one, the first letter will be a A. If we have a wedge fractures means that we have this intermediate fragment or a butterfly fragment. The first letter will be a B. If we have a complex fracture, The first letter will be a C. As you can see here, 4-2A simple, 4-2B a wedge fracture, 4-2C a complex fracture of the tibial diaphysis. At the clinical examination, we will see the same things: pain, swelling, deformity, ecchymosis, shortening, vicious position, abnormal mobility, crepitations, and so on. We will ask for an anteroposterior and lateral X-ray view of the lower leg. As I said yesterday, we need to see the above and below joints in the X-rays views. In all cases, and it doesn't matter the segment, the lower limb, the upper limb, we must visualize the above and below articulations. There is a complication called the compartment syndrome. It can appear in all segments of the upper and the lower limb, but we will treat this syndrome here because it is most frequent at the level of the lower limb, lower leg. This complication, it's a limb and life-threatening condition when after an injury, after a trauma, there is insufficient blood supply to the muscles, nerves, and arteries into a compartment. What happens? The fascia layer is inextensible. After a bleeding, so on a hematoma, or if we have an edema of the muscles of a crushing syndrome, this bleeding or edema will lead to an increased pressure in the compartment. After a while, this intracompartmental pressure will be higher than the pressure in the venous system. That means that the veins will collapse. All the blood will remain here in the compartments, and the arteries will continue to bring blood in this compartment. At one moment, the pressure in the compartment will exceed the systolic tension. That means that also the artery will collapse. We don't have any blood supply. We don't have an oxygen supply in this compartment. The blood supply will be interrupted, and that will lead to necrosis of the muscles, nerves, and vessels, and the lesions will be irreversible in 6 hours. So this compartment syndrome, it's an emergency, and it must be treated as an emergency in the first 6 hours after its debut. How do we diagnose the compartment syndrome? It is simple. By measuring the intracompartmental pressure with a manometer like in these images. And the treatment will be immediate fasciotomy. Even if only one compartment is affected at the level of the segment, this fasciotomy must release all the compartments. At the level of the tibia and the peroneum, so between the knee and the ankle, we have 4 compartments. We have an anterior compartment, a lateral compartment, a deep posterior compartment, and a superficial posterior compartment. So the fasciotomy must release all 4 compartments. This can be done by 2 fasciotomies, one on the lateral side and the other on the medial side, or you can perform only one fasciotomy on the lateral side, and you can go anteriorly and posteriorly from the peroneum and release all 4 compartments. This is a fasciotomy. The patient had also a fracture of both bones, and it was treated by reduction and osteosynthesis with an external fixator. And this fasciotomy will be closed in the next 3 to 4 days when the symptoms disappeared, and it cannot be closed by simple suture. Usually you will need skin grafts from the plastic surgery in order to close the wound. And when you close this fasciotomy, you will close only the skin and the subcutaneous fat, so no suture at the level of the fascia. Concerning the fracture will be treated by orthopedic means or by surgical procedure. The options for surgical procedures are open reduction and internal fixation with plates and screws, or close reduction and osteosynthesis with a centromedullary nail, and this is the preferred method of treatment. The nail can be removed, unremoved, statically or dynamically locked. For the tibia, we have only anterograde nails. At the level of the femur, we have anterograde and retrograde nails. For the tibia, we have only anterograde nails. And the third option is the reduction and osteosynthesis with an external fixator, which is indicated when we have an open fracture or when we have extensive lesions of the skin or of the soft tissues. The orthopedic treatment is indicated when we have a fracture without a displacement, or a fracture with minimal displacement, or in patients in which the comorbidities contraindicate any anesthesia or surgical treatment. The orthopedic treatment consists in immobilization in a femoropodal cast or a long leg cast, it's the same thing, for 6 weeks. And after that, immobilization in a Sarmiento cast for another 4 to 6 weeks. What is this Sarmiento cast? It is called also a PTB cast in the Anglo-Saxon literature, and that means patella tendon bearing cast. It's a cast that is well fitted below the knees, well fitted to the patella and the femoral condyles, and most part of the patient weight it's borne on the patellar tendon region anteriorly, so on the cast and not to the bones. Another method of treatment is transcalcaneal traction on a brown splint for 3 weeks, and after that immobilization in a femoropodal cast for 3 weeks and Sarmiento cast for 4 to 6 weeks. This kind of treatment is indicated when we have a displaced fracture, but we cannot perform a surgical procedure. The aim of the transcalcaneal traction is to obtain to some degree a reduction. We will not have a perfect reduction, but it's something. So this traction will perform in time, will lead in time to some reduction, and after that immobilization in femoropodal and Sarmiento casts. Our first choice in the treatment of this fracture, if we have a displaced fracture, it's osteosynthesis with a centromedullary nail. It's an anterograde nail. Here we have a statically locked nail. That means that we have 2 screws distally in the round holes and other 2 screws proximally also in the round holes. So it is statically locked. After such a surgery, the patient can walk with partial weight bearing at 2 to 3 days after surgery, and complete weight bearing at 10 or 12 weeks after surgery, depending on the type of fracture and the evolution towards union. Another method of treatment is reduction and osteosynthesis with plates and screw. We have some disadvantages. We will lose the perifractural hematoma with all the cells and substances that promote union. And the main disadvantage is that in such a case, the patient can walk with weight bearing at 3 months after surgery. The main advantage of the nail is that it allows walking with weight bearing from the first days after surgery. The reduction in osteosynthesis with external fixator is indicated in open fractures, or like in this case, when we have extensive lesions of the soft tissues at the level of the fracture. Complications, blah, blah, blah. And we have the fractures of the ankle, which are the supramalleolar. We have the supramalleolar fracture. We have the fractures of the tibial pylon. That means any fracture that goes inside the ankle joint. And we have the fractures of the malleola. Fracture of the tibial malleola, peroneal malleola, of both malleolas, or of 3 malleolas. The supramalleolar fractures are all extra-articular, and it are located between 2 to 6 centimeters above the ankle joint line. If it is below 2 centimeters, it is certainly a fracture of the tibial pylon. If the fracture is located at more than 6 centimeters above the ankle joint line, it will be classified as a fracture of the tibial diaphysis. There are rare, these kind of fractures. An example, we can see here a fracture which is located between 2 to 6 centimeters above the joint line. We don't have any fracture line in the joint, in the ankle joint. So it's an extra-articular fracture. We have also a supramalleolar fracture of the peroneum in this case. In such a case, the treatment will be the surgical one, reduction and osteosynthesis with a plate for the tibia and another plate for the peroneum. When we clinically examine such a fracture, we can see important edema with local hematoma, blistering, which is very frequent in this region, osseous continuity, crepitation, functional impotence, pain, of course, abnormal mobility or antalgical limited mobility of the ankle, deformity, and the diagnosis will be based on the anteroposterior and lateral Eric's view of the ankle. For the supramalleolar fracture, the treatment can be the orthopedic treatment or the surgical treatment. The orthopedic treatment is indicated in fractures without displacement or with minimal displacement, or when we have contraindications of the surgical treatment. In this case, if the fracture is displaced, of course that we will perform an orthopedic reduction, and after that immobilization in a long leg cast for 6 weeks and a Sarmiento cast for the next 4 weeks. And the patient will walk without weight bearing for the first 6 to 8 weeks. we don't have fixed intervals, but we have these variables because there are no identical fractures. The period of immobilization depends on the type of the fracture and on the evolution of the fracture. The surgical treatment for the supramalleolar fracture consisted reduction and osteosynthesis with plates and screws, like in this image. We have a supramalleolar fracture treated by reduction and osteosynthesis with 2 plates for the tibia, and we have also an associated supramalleolar fracture on the peroneum, and that was treated by reduction and osteosynthesis with plate. Another option is to mount plates for the tibia and use a Kirschner wire for the peroneum. So here, a plate or maybe 2 plates in some cases. For the peroneum, 1 plate or 1 Kirschner wire. Fracture of the tibial pylon. All fractures of the tibial pylon are intra-articular. That means that we have a fracture line that goes inside the joint line. Like here, the fracture starts somewhere here and it goes into the joint. These are 2 images from a CT scan. This is a frontal slice. This is a sagittal slice, and we can see that the fractures goes into the joint line. So these are fractures of the tibial pylon. At the clinical examination, we will see the same things as in the supramalleolar fractures. Edema, blistering, hematoma, osseous discontinuity and crepitation, abnormal mobility, deformity, and so on. You should ask for an anteroposterior and lateral Eric's views of the ankle, but also of the lower leg and foot, because they are here in the area. And if you perform a reduction, anytime in orthopedics, if you perform a reduction, you must ask for another round of Eric's views after reduction in order to see if your reduction is good enough and in order to have a starting point for the next Eric's checkups to see where do you start. A CT scan is useful in order to see all the fracture lines, the fragments, their dimensions, and their displacement. Here we have the same case. This is the anteroposterior Eric's view. You can see a comminuted fracture of the tibial pylon and a fracture of the peroneal malleolus. This is a CT scan, a frontal slice. You can see that the fracture is more complex on the CT scan. And this is a 3-dimensional reconstruction made also by a CT scan. The treatment. The same things. The treatment will be indicated in fractures without displacement or with minimal displacement, or if you cannot perform a surgical procedure. If the fracture is displaced, you will perform an orthopedical reduction. The immobilization will be in a long leg cast for 6 weeks and a Sarmiento or a boot cast for the next 4. The surgical treatment will be reduction and osteosynthesis with plates and screws. As you can see here, we have a fracture of the tibial pylon fixed by a plate. And we have also a fracture of the lateral malleolus treated by reduction and osteosynthesis with plates. We have a peculiar type of osteosynthesis which can be performed here, but also in other regions. and this is the mixed osteosynthesis. The mixed osteosynthesis means the association um, of an external fixator and some screws introduced by mini-invasive approaches. This kind of osteosynthesis is indicated in open fractures when you have extensive skin lesions that doesn't allow a normal approach, a normal extensive approach, surgical approach, or when you have severe comminution. When you have a severe comminuted fracture, if you largely open the fracture site, you will lose the hematoma, but also many small fragments. And if you lose them, you cannot put it back, and you cannot obtain acceptable reduction. So in these cases, in explosive fractures, you prefer not to open the fracture site, but to mount an external fixator in order to restore the length and the axis of the segment. And you can introduce screws by mini-invasive approaches in order to reduce and fix the bigger fragments. So this is the mixed osteosynthesis, an association between an external fixator and screws. Complications, the same. The malleolar fracture. The malleolar fractures means fractures of the lateral malleolus, of the medial malleolus, of both malleolus, or the so-called trimalleolar fractures. And we will discuss each of them. The usual mechanism is the indirect mechanism. It's a forced movement in the ankle, like here in varus, or on the other side in valgus. That happens in sport accidents or on walking on uneven soil. We have a peculiar clinical entity called the Maisonneuve fracture. It's an association of three lesions. We have a spiral fracture of the proximal third of the peroneum. We have a tear of the distal tibiofibular syndesmosis. That means a lesion, a complete lesion of the tibiofibular distal ligaments, and a fracture of the medial malleolus, or a complete lesion of the deep deltoid ligament, which is located here between the tip of the tibial malleolus, the astragalus or the talus, and the calcaneum. So this association of three lesions is called the Maisonneuve fracture. It's a guy, it's a French guy, and his name means new home, new house. A trimalleolar fracture. It's a fracture that involves the lateral or peroneal malleolus, the medial or tibial malleolus, and another fracture on the distal posterior region of the tibia, which is the so-called posterior malleolus. In this case, it's a trimalleolar fracture. We have a fracture of the lateral malleolus, a fracture of the medial malleolus, and a fracture of the posterior malleolus, which is better viewed here on a CT scan on a sagittal slice. This is the fracture of the posterior malleolus. In such cases, the ankle will be unstable in all plans because it can dislocate anteriorly, posteriorly, medially, laterally. So it's a very unstable ankle. In order to obtain a stable ankle, we must reduce and fix all these three fractures. And as you can see here, we performed osteosynthesis with a plate for the for the peroneal malleolus, another plate for the posterior malleolus, and two screws for the medial malleolus. As you can see here, we have a posterior plate for the fracture of the posterior malleolus. Another case of a trimalleolar fracture, we have fracture of the lateral or peroneal malleolus, fracture of the medial or tibial malleolus, and a fracture of the posterior malleolus. A postoperative image after reduction and osteosynthesis with plate and screws for the peroneal fracture, two anteroposterior screws for the posterior malleolus fracture, and other two screws for the fracture of the medial malleolus. We prefer to use two screws inside of one only, because by using two screws, you will block also the rotation of the fragments. If you will use only one screw, the fragment can rotate around the axis represented by the screw. So, if it is possible, you must use two screws. If it is possible, means that you have a large enough fragment in order to accommodate two screws. In some cases, the fragment is too small in order to introduce two screws to it. And these are the images at 1 year after surgery, after the removal of all metallic implants. At the clinical examination, we will see the same things, but we have also some specific findings. If you have a tibio-peroneal diastasis, and I will explain you later what that means, the transversal diameter of the ankle will be increased. If we have a posterior dislocation of the ankle, that means that the talus will go posteriorly. This is why it is a posterior dislocation. The calcaneal region will be proeminent, while the foot will appear to be shortened. If we have a dislocation in the other direction, if we have an anterior dislocation of the ankle, that means that the talus will go anteriorly, will dislocate anteriorly. The calcaneum region will be less proeminent, of course, and the foot will appear to be longer. So by clinical examination, you can have an idea if we have diastasis or if we have anterior or posterior dislocation of the ankle. The diagnosis will be made by radiological examination by the two classical incidences, the anteroposterior and lateral helix view of the ankle. As I said, there is a clinical entity called the diastasis. In a normal ankle, the peroneum will overlap the tibia for 6 to 8 millimeters. This is the normal ankle. If we have lesions at this level, lesions of the distal tibio-peroneal ligaments, These two bones will go away and we will have a space, an abnormal space between the two bones at the level of the ankle. This space is called tibio-peroneal diastasis. If we have such a lesion, this lesion must be treated also. And in this case, we have a fracture of the tibial malleolus, which will be treated by reduction and osteosynthesis with screws or a figure of 8 tension band. And for this diastasis, we will reduce and fix the diastasis by a long interfragmentary screw. For the fracture of the peroneal malleolus, if the fracture is without displacement, the orthopedic treatment will consist in immobilization in a short leg walking cast. Short leg means below the knee cast for 4 weeks with weight bearing from the start. Or, of course, you can use an orthesis. So, a fracture of the peroneal malleolus, it's a luckier fracture, because if it is without displacement, the patient can walk with weight bearing from the start. If we have a minimal displacement, the immobilization interval will be longer. It will be 6 weeks, and without weight bearing for the first 2 weeks. If the fracture is displaced, a surgical treatment will be indicated. It consists in open reduction and osteosynthesis with plates and screws. In some cases, the patient or the physician can opt for an orthopedic treatment, and that will consist in reduction and immobilization in a boot cast for 6 weeks. The first 2 with walking without weight bearing. So the fracture of the peroneal malleolus can be treated by orthopedic treatment in all cases. Even if you have a displaced fracture, if you obtain a good reduction by orthopedic means, you can use the orthopedic treatment, immobilization in a cast. For the tibial malleolus, if the fracture is without displacement, demobilization will be in a boot cast for 6 weeks and without weight bearing for the first 4 weeks. So it's a big difference. For the peroneal malleolus without displacement, 4 weeks and weight bearing from the start. For the tibial malleolus, even if the fracture is without displacement, demobilization will be for 6 weeks and without weight bearing for the first 4. If the fracture is displaced, we can perform a reduction, an orthopedic reduction, and if the result is a good one, if we attain a good reduction, we will immobilize the ankle in a long leg cast and above leg cast for 6 weeks and the Sarmiento walking cast for another 4 weeks. The weight bearing will be allowed at 8 weeks, and we must check the reduction at 1 week and 2 weeks after reduction in order to check if the reduction is maintained in time. Usually, in a displaced fracture of the tibial malleolus, the treatment is the surgical one, and it consists in open reduction and osteosynthesis with 2 interfragmentary screws or with a figure of 8 tension band. This figure of 8 tension band is made by 2 Kirschner wires. Here we have 3, but usually we use only 2. 2 Kirschner wires one screw, and a figure of 8 Kirchner wires, which goes around the curved tips of the Kirchner wires and around the flower of the screw. Weight bearing is allowed at 8 or maybe 12 weeks after surgery. It's a much more complicated fracture than the fracture of the peroneal malleolus. For the bimalleolar fracture, the treatment, the orthopedic treatment, it's the same as the treatment of the tibial malleolus. If the fracture is without displacement, we will immobilize the ankle in a long leg cast for 6 weeks without weight bearing for the first 4. It's the same thing as for the tibial malleolus fracture. If it is displaced, we will perform reduction, immobilization in a femoropodal cast for 6 weeks and the Sarmiento walking cast for another 4 weeks with weight bearing at 8 weeks. It's the same thing as for a fracture, a displaced fracture of the tibial malleolus. For a displaced fracture, the first option is to perform a surgical treatment. Of course, it is different from the fractures of the tibial malleolus because we must address also the fracture of the peroneal malleolus. And the treatment will consist in open reduction and osteosynthesis with a plate for the peroneal malleolus and reduction and osteosynthesis with screws or with a figure of 8 tension band for the medial malleolus. So, in order to summarize, for the peroneal malleolus, almost in all cases, plate. For the tibial malleolus, 2 screws or figure of 8 tension band. That depends on the preferences of the surgical physician. For the tibial peroneal diastasis, the treatment consists in reduction and fixation by an interfragmentary screw. As you can see here, we have a supramalleolar fracture on the peroneal side, a fracture of the tibial malleolus, and a large diastasis here between the 2 bones. In this case, the ankle is very large and it's very unstable. We must fix the fractures, but we must also restore the dimensions of the ankle. And this is done by this interfragmentary screw. Another case, a bimalleolar fracture with diastasis. The fracture of the tibial malleolus was fixed by a figure of 8 tension band, 2 Kirchner wires, 1 screw, 1 small screw here, and 1 figure of 8 wire. For the fracture of the peroneal malleolus, we perform reduction and osteosynthesis with a plate. And for the diastasis, we reduce the diastasis and we fix it with this large interfragmentary screw. This interfragmentary screw will be removed at 6 to 8 weeks after surgery in order to allow a better recovery because it tightens the ankle and it will impair the recovery of ankle mobility. So this one, it is usually removed at 6 to 8 weeks after surgery. The normal interval for removal of the metallic implants is 1 year after surgery. So the figure of 8 tension band and the plate will be removed at 12 months after the initial surgery. Complications, and let's try something else. Let's try to identify the fractures and maybe to guess an indication for treatment. For the first picture, I will do that, and for the next pictures, we will try to do it together. So this is the fracture of the tibial plateau. It's a Schatzker type 6 fracture. Why? Because we have a fracture on the lateral plateau. This is the split. This is the depression. This is the articular surface. It should be here, not here. We have another split fracture on the medial plateau, and we have also a fracture of the peroneal head here. The treatment will be a surgical one, of course. It means reduction and osteosynthesis with a plate. We will lift this depression. We will bring the articular surface here at its normal place. By doing so, we will remain with a cavity here. This cavity must be filled with something. And usually, we will use an autograft harvested from the iliac crest. After that, a long length plate will be mounted here with at least 3 screws below the most distal fracture line. The patient can mobilize the knee from the start, but he or she will be allowed to walk with weight bearing at 3 months after surgery. So 3 months without weight bearing on this knee. Can you guess or can you see what kind of fracture do we have here?
I don't think you've changed the slide.
Ah, okay. Oh, so we have the same problem. The problem is that when I do that, you can see also the diagnosis. You can see the image right now?
Yes.
Okay. Maybe a guess? It's a Schatzker type 3 fracture. It's a fracture located in the lateral hemiplateau, and it's a pure depression. We don't have any split in this case. The treatment will be lifting of the articular surface, introduction of a spongious structural graft in the remaining cavity, and fixation by plate and screws. Another one. I think that it's a more simple fracture.
Fracture type 1.
I'm sorry?
Type 1.
Type 1. Yes. Very good. It's a type 1 in the Schatzker classification. It's a split fracture located on the lateral plateau. We have also a fracture of the peroneal head. You must be careful because in some Eric's view, you can see from the starting point a fracture, and you can lose other fracture if you don't carefully examine the whole picture. So we have this split fracture. It's a type 1 fracture, and it can be treated, it's without a displacement. It can be treated by orthopedic treatment, so immobilization in a cast. But for myself, I will prefer to perform an osteosynthesis with 2 or 3 screws introduced by minimally invasive approaches on the lateral side, and we will introduce these screws under C-arm control, and the patient will have a free knee to mobilize, but it will be allowed, he or she will be allowed to walk with weight bearing at around 8 weeks after surgery. How about this one?
It's type 2.
It's type 2. Bravo. It's the most common type. It's a fracture of the lateral hemiplateau. The treatment will be lifting of the articular surface, mounting an autograft harvested from the iliac crest, and osteosynthesis with a plate and screws. The patient can mobilize the knee from the start, but walking with weight bearing will be allowed at 3 months after surgery. This one? It's much more complicated because we have another fracture line in the medial plateau. You can see the large depression. And we have also splits, one in the medial plateau, one in the lateral plateau. It's a type 4. It's a type 5, excuse me. It's a type 5 fracture. It's a bicondylar fracture. We have a fracture with depression and split in the lateral plateau, and another split fracture in the medial plateau. The treatment will be the same. Lifting of the articular surface, lifting of this articular surface that must be here. We will use an autograft in this area and reduction and osteosynthesis with a plate. I think that's a simple one as diagnosis and also as treatment. Ideas?
It's a tibia fracture.
Yes. At what level of the tibia? It's a fracture of what segment of the tibia?
Diaphysis.
The diaphysis, it's a fracture of the diaphysis. It's comminuted. That means that we have 3 or more fragments. The peroneum is also fractured. And the treatment will be
intramedullary nail.
yes, we will use an intramedullary nail. It is introduced to the proximal tibia, so we have only anterograde nails for the tibia. And in this kind of fracture, we can use this centromedullary nail, which is statically locked because we have screws in the round holes distally, but also proximally. And in this kind of fracture, the patient can walk with weight bearing from the first day after surgery. It is a fracture with minimal displacement. You can use also the orthopedic treatment, but it's very difficult for the patient to stay the first 6 weeks in a long leg cast, and after that other 4 weeks in the Sarmiento cast. That means 2 months and a half in a cast without weight bearing for the first 2 months. it's a long period of time. It is much more easy for the patient to undergo a surgical procedure like this one, osteosynthesis with a centromedullary nail, that will allow him or her to walk with weight bearing from the first day after surgery. It's a normal person in one day. What kind of fracture do we have here?
Fracture of tibial pilum.
Exactly. It's a fracture of the tibial pylon. Why? Because the fractures goes into the joint line. We have also a fracture of the peroneal malleolus, and in such a case, because it's a very explosive fracture, I think that the best option is to perform a reduction and osteosynthesis with a plate at the level of the peroneal malleolus. And for the tibial pylon, we can use a mixed osteosynthesis. We can mount an external fixator, and we can use screws in order to reduce and fix the larger fragments. Let's try to identify the fracture and also to indicate the optimal treatment. What kind of fracture is it? What it is fractured?
Bimalleolar fracture.
Yes, it's a bimalleolar fracture. Why? Because we have a fracture of the tibial malleolus, but also a fracture of the peroneal malleolus. Fracture of two malleolae means bimalleolar fracture. How about the treatment? What do you indicate in such a case?
Plate for the fibular one, and then screws for the tibial.
Yes, it's a very good answer. We will use a plate for the peroneal malleolus, and for the tibial malleolus, we can use two screws or a figure of 8 tension band. In this case, what is fractured? What other lesions do we have? Any dislocation, maybe?
Again, a bimalleolar fraction with a widening of the bone, so diastasis.
Okay. And
Dislocation of the ankle.
dislocation. For the dislocation, in order to identify the dislocation, it matters where goes the distal bone in the joint. In our case, the distal bone is the talus. If the talus goes posteriorly, like in our case, we have a posterior dislocation. If it goes anteriorly, we will have an anterior dislocation. In this case, on the lateral Eric's view, we have a posterior dislocation, and in the antero-posterior Eric's view, we have a lateral dislocation. In such a case, the treatment will be a plate For the peroneal malleolus, two screws or a figure of 8 tensioned band for the tibial malleolus, and the long interfragmentary screw for the diastasis. We will remove the interfragmentary screws at 8 weeks after the initial surgery, and all the other metal implants will be removed at 12 months after surgery. It's a simple one, I think, as diagnosis, but also as treatment.
Perianal malleus fracture.
Yes, very good. It's a simple one or a comminuted one.
It's simple.
It's a simple one. With displacement or without displacement?
I think it's without displacement.
Without any displacement. What do you indicate as a treatment?
Weight bearing for 4 weeks.
Yes, but an immobilization, I think, yes?
Yes.
Immobilization in what?
Mm-hmm.
Short leg cast.
Yes, in a short leg cast, in a walking cast or a Sarmiento cast with weight bearing from the start. The immobilization will be maintained for 4 weeks, and in this period of time, you should indicate thromboprophylaxis with low weight heparins. The last two topics for today are fractures of the talus and fractures of the calcaneum. The talus or the astragalus is covered by cartilage on around 60% of its surface. There are no muscular insertion at its level, and this is why the vascularization is limited. All the vessels enters the astragalus, the talus, at the level of the neck. The talus has three parts: the head in the front, the neck in the middle, and the body of the talus in the back. And all the vascular supply is located here at the level of the neck. It's a very rare fracture. They represent less than 1% of all fractures. And why it's that? Because when the patient, the individual, falls from a height below the talus, we have the calcaneum, which is a spongious bone. It's a more fragile bone. And in fall from height, in most of the cases, the fracture will involve the calcaneum and not the astragalus. This is why the fractures of the talus are very rare, because below it we have a more fragile bone, the calcaneum. The fractures of the talus can be classified as fractures of the neck, fractures of the body of the talus, and parcellar fractures that can involve the head. We can have osteocartilaginous fractures of the dome, like here. Here we have a small fracture. We have a small osteocartilaginous fragment, which is not displaced because it's right in the middle of the ankle, and it doesn't have enough space to be displaced. Or we can have a parcellar fracture of the posterior apophysis of the talus, as described by Shepard. This is a Shepard fracture, a fracture of the posterior apophysis of the talus. At the clinical examination, if we have an undisplaced fracture of the talus, the patient will describe only pain. We will see also swelling, ecchymosis, and pain at the front of the tibial malleolus at the mobilization of the ankle. It's an area also prone to blistering, edema and blistering. In order to identify and diagnose the fracture, we will use the classical anteroposterior and lateral Eric's views of the ankle. And for the talus, we have a third special incidence, the oblique incidence with the foot rotated at 15 to 20 degrees. And this kind of special incidence is useful in order to visualize the fractures of the neck. Of course, that the CT scan is very useful in these cases. The image in the middle represents a comminuted, displaced fracture of the body of the talus. This is the head. Here we have the neck, and here is the body with this fracture. Below we have the calcaneum, and above it's the tibial pylon. Another image, a sagittal slice in a CT examination, and we can see a parcellar fracture of the posterior apophysis of the talus. It's a shepherd fracture. This is the talus. We have the head, the neck, and this is the body. Above we have the tibial pylon, and below we have the calcaneum. Here in front of the talus we have the navicular bone. The treatment. The treatment can be an orthopedic one or the surgical one. The orthopedic treatment is indicated in fractures without displacement, and the ankle and the foot will be immobilized in a boot cast for 6 to 8 weeks without weight bearing for 3 months. Even if the fracture is without displacement, because we have a high risk for osteonecrosis, the patient will be allowed to walk with weight bearing after 3 months after trauma. If the fracture is displaced, the treatment will consist in reduction and osteosynthesis with screws. The first image, it's an intraoperative image from the C-arm device. The patient had a fracture of the neck of the talus, and we performed reduction and osteosynthesis with screws under C-arm control. The image in the middle, it's a fracture of the body of the talus. It's a post-operative image after reduction and osteosynthesis with screws. Because the talus is surrounded by other bones, by the tibial pylon, by the peroneal malleolus, by the calcaneum, and the navicular bone, it is very difficult to approach this bone. So in some cases, in order to see and in order to reduce the fracture, we will perform an osteotomy of the peroneal malleolus, which will be, of course, fixed after surgery, after reduction and osteosynthesis of the talus fracture. There are a number of complications. Most of them are the usual complication, but we have a specific complication, which is the avascular necrosis This is due to the limited vascular supply and due to the fact that all the arteries penetrate the talus at the level of the neck and at the level of the sinus tarsi. If we have a fracture of the femoral neck, most of these arteries will be interrupted and the vascular supply of the talus will be interrupted. When the talus is enucleated, that means that the talus leaves the space between the tibial pylon and the calcaneum, as in the Eric's view, the risk of necrosis is very, very high. It's around 75% of cases. The fractures of the calcaneum represent around 20% of all fractures, and their frequency is much, much higher among male patients. 7 to 15% of fractures of the calcaneum are open, depending on the study, and this is due to the fact that the calcaneum is covered by only skin and some very, very thin layer of fat. There are no muscles at this level. There are some tendons, some nerves, some arteries, and a very thin layer of fat and a very thin skin here. So the calcaneum is just under the skin. The usual mechanism is falling from heights, and because these are high energy traumas, in many cases we will find also other lesions like fractures of the lower limb, fractures of the pelvis, or fractures of the thoracolumbar spine. In order to describe the fracture, we will use the Böhler's angle. This Böhler angle is formed by the intersection of two lines. The first one is drawn tangent to the most upper point of the posterior calcaneus and the higher point of the calcaneus, while the second line is drawn tangent to the most upper point of the anterior calcaneum and the most elevated point of the whole calcaneum. Between these two lines, we have the so-called Böhler's angle, which has a normal value between 25 and 40 degrees. We have two classifications for the fractures of the calcaneum: the Essex-Lopresti classification and the Böhler's classification. The Essex-Lopresti classification is based on the direction of the fracture line. These fractures can be extra-articular, 1/4 of it, and 3/4 of the fractures are intra-articular. These intra-articular fractures are classified in two types of fracture: the joint depression calcaneal fracture and the tongue type fracture. These are the two types. On the left, we have the depression type fracture. In this fracture, the main fracture lines goes vertically. The secondary fracture line goes up and posteriorly, and it will eject on the superior side of the calcaneum. So the primary line, it's a vertical one, and the secondary line will leave the calcaneum on its superior aspect. This is the depression type fracture. In the tongue type fracture, the primary fracture line is also vertical, but the secondary line goes horizontally and it will leave the calcaneum on its posterior aspect. And these fragments mimics a tongue. This is the tongue fragment. In the depression type fracture, the primary fracture is vertical. The secondary line will leave the calcaneum on its superior face. In the tongue type fracture, the primary line of fracture is the same, it's a vertical one, but the secondary fracture will go horizontally and it will leave the calcaneum on its posterior surface. The second classification for the fractures of the calcaneum is the Böhler classification. It is used only for the thalamic fractures. The thalamic fractures are the fractures at the level of the thalamus. And the thalamus of the calcaneum is the central region of this bone. It is reinforced and it's the most resistant part of the calcaneum. We can determine the Böhler's angle on lateral Eric's view of the posterior foot, and if the Böhler angle has a positive value, we have a type 1 fracture. If the value of the angle is 0, that means that all 3 points are located on the same line, are collinear, we have a type 2 fracture. And if the Böhler's angle has a negative value, that means that this higher normally point goes below the other 2 points and we have a negative Böhler angle, the fracture will be of the 3 type. At the clinical examination, we will observe pain, ecchymosis at the level of the lateral malleolus, special, peculiar plantar ecchymosis, which is called the nummular plantar ecchymosis. Nummular means in Latin cone-like form. And you can see here this peculiar ecchymosis right in the middle of the plant. Blistering, as in most cases in this area, and important edema with dilation of the malleolar reliefs. The patient has pain and he or she cannot walk on a fracture of the calcaneum because it's the main support region for the lower limb. As I said, there are a number of associated lesions in many cases, fractures of the lumbar vertebral column, other fractures of the lower limb, lesions of the soft tissues, sometimes compartment syndrome, and open fractures because the calcaneum is located just under the skin. We should ask for the 2 classical incidences, the anteroposterior and lateral Eric's view of the leg, and for the posterior part of the calcaneum, we have a 3rd incidence, the axial Eric's view of the calcaneum. In thalamic fractures, which are usually comminuted and displaced, a CT scan is very useful in order to see all the fragments, their dimensions, their displacement, and so on. On the left, we have type 2 fracture in the Böhler's classification because all the 3 points are located on the same line, are collinear. And in the Essex-Lopresti classification, it's a tongue type fracture because the primary line is almost vertical and the secondary line goes posteriorly and it leaves the calcaneum here on its posterior aspect. The treatment, it can be an orthopedic treatment or a surgical treatment. The orthopedic treatment is indicated in fractures without or with minimal displacement, and of course in cases where comorbidities contraindicate anesthesia and a surgical procedure. The orthopedic treatment consists in immobilization on a Graffin type cast with anterior bearing for 6 weeks. This is a special type of cast with this anterior bearing device and with a free room in the back from the calcaneum. This kind of immobilization will allow patient to walk with early partial weight bearing because most of the forces, most of the compression forces will be transmitted from the tibia towards the astragalus and on the forefoot. So there are no compression forces at the level of the fractured calcaneum. After 6 weeks, this kind of immobilization will be removed. The patient will remain with a free lower leg, but complete weight bearing will be allowed at 3 months after trauma because it's the main point of support for the whole body. We walk on our calcaneus. If we have a displaced fracture, a fracture of type 2 or type 3 in the Böhler classification, we can perform a number of surgical procedures. We have 3 options here. The first one is open reduction and osteosynthesis with plate and screws or with Kirchner wires. Because in such cases we have large depressed fragments, after reduction we have a restant cavity, and this cavity will be filled with something, usually with autograft harvested from iliac crest. On the right above we have a normal extensive approach for the calcaneum, and here we have a post-operative image after reduction and osteosynthesis with a plate. We can see that the height of the calcaneum was restored and the articular surface also very well reduced. The second option is the percutaneous minimal osteosynthesis with Kirchner wires under C-arm radiological control. Here is an example. We perform only minimally invasive approaches. We introduce some metallic instruments in order to elevate the depressed fragments. This is the image after reduction and fixation with 4 Kirchner wires. Our third option is the reconstruction arthrodesis described by Stutz. It is indicated in severe comminution that makes impossible the, an optimal reduction of the articular surface of the calcaneum. If we leave the articular surface unreduced, that will lead to osteoarthritis in the astragalocalcanean joint, and the patient will walk with pain at this level. In this case, we will remove the articular cartilage in the astragalocalcanean articulation, and we will fix the fracture and the two bones one to the other by Kirschner wires. By doing so, we will remove the articulation between the astragalus and the calcaneum. It is a joint that doesn't move, so it's not a problem that we remove this articulation. And the patient will walk with weight bearing at 3 months after surgery. The complications, the most frequent complication is skin necrosis in extensive approaches to the calcaneum, and in some cases we will see the patient developing an astragalocalcanean osteoarthritis. This is all for today. Thank you for your attention.